As the sixth of seven children and a competitive athlete, Frank Jackson was well prepared for the rough and tumble of healthcare. After studying computer science and accounting, he pursued a variety of healthcare analytics roles before jumping into operations at HealthMarkets, where he helped the company pivot as the Affordable Care Act became law. At Prognos, he helped unleash the power of lab data on healthcare decision-making. As general manager at Wolters Kluwer Health, he's deploying technology such as natural language processing and code translation engines to help payers contend with the COVID-19 whipsaw. I'm David Williams, host of the Health Biz podcast and president of Health Business Group, a strategy consulting firm that helps healthcare companies develop robust growth plans. Reach out to me, dwilliams@healthbusinessgroup.com, if you'd like to discuss strategy issues for your healthcare or life sciences company. Frank Jackson, General Manager from Wolters Kluwer Health Language. Thank you for joining me today on the Health Biz Podcast.
Thank you, David. I appreciate the invitation. Look forward to the discussion.
Sounds great. Now, listen, we're going to talk about things you're working on today, but I want to wind the clock back, if you don't mind, and just talk about your background, your upbringing, your childhood influences. What was your childhood like?
Yeah, David, I came from a very large family. I was number 6 out of 7, so certainly influenced by the large family and my siblings. I kind of grew up in South Bend, Indiana, right on the shadows of the campus of Notre Dame. My dad was a big influence. I had a great parents. My childhood was really filled with playing sports. I was influenced by competition and playing sports, everything I played all the way through parts of college. And so sports is really part of my upbringing. My whole family's that way. So, but it's been good. It's been really good. I'm a Hoosier at heart.
Yeah, no kidding. Now, Frank, listen, when you were the 6th out of 7, so my question is this: were your parents dissatisfied, with having you as the last one, or they say, this Frank's so good, we got to have one more?
We've often asked. I think when they figured out that I was the worst behaving when it was too late, they had my daughter.
That's what happens sometimes. But in any case, it's nice to be part of a large family. Sometimes I think it's not always so great for the parents, but it's definitely good for the siblings. So that sounds terrific. Now, on your education, I think you did computer science and accounting. How did you come across that as a path?
Yeah, I think two things. One, I loved math, and I won a contest of writing a computer program in high school, and sort of fell in love with it of computer science in the early days of it. But I was always interested in the intersection of that technology with business, and a mentor in high school suggested that accounting was a good way to understand the building blocks of business. So so I always was interested in the intersection, and I've stuck with it for over 25 years.
Now, pretty soon into your career, you started working in the healthcare space. Why did you pick healthcare, or was it more or less by accident?
Well, I think it was serendipitous in the beginning, David, but I quickly fell in love. I started working for a boutique healthcare company and as a consultant, and one of the first things I was assigned was there was a hospital entity that was building a health plan. So I got to work on kind of building from scratch a health plan, and then shortly after that, I began working with doctors at the Kaiser Permanente and clinical strategy, and I just fell in love with the impact I could make. Especially at Kaiser, where I saw these doctors were really open to innovation, and at least in the early days, it progressed so far now. But I could see where technology and data impacted the way they delivered care, and ultimately kind of the outcome of patient health. So I just fell in love with the idea of making an impact, and there was a lot of frontiers in healthcare when I got in it, and they still are, but it's accelerated by so much. But just making a difference is how I kind of fell in love with it.
No, that's good. I think a common story as well for those of us who are in the space. Now, before coming to Wolters Kluwer, a couple of places that you had major stints were HealthMarkets and Prognos. What were some of the highlights of those?
Yeah, at HealthMarkets, we were a individual health plan. We manufactured, underwrote individual plans. So we did that, and we also were one of the largest distribution brokers in the space. We had about 3,000 brokers. We were about 900 million in revenue. So we were owned by Blackstone, one of the largest private equity. And I would say the highlight there, or the interesting there, is when Affordable Care was passed 2010 or so, it impacted our business. So we did a complete pivot within 9 months of moving to selling different products and changing the way we distributed product. And so it was really a great lesson on that I was able to kind of touch all aspects of healthcare, not just every aspect of operations within the health plan, but also how it was distributed and sold, and how did brokers operate, from individual insurance to Medicare. So it was just a great opportunity to see how things kind of worked. And then in Prognos was my first job in terms of working in a venture-backed startup. It was a 6-year startup, and it was mission was around improving health of everyone in the country. And it was an analytic and driven insights, and working with venture, but also driving through AI, improved care was in a venture-backed kind of model, which is really, really informative. And I came in to actually start a whole payer vertical for them. So it was nice to start, greenfield, and say, hey, what the payers really need and want. And, I did a lot of research. It was just really, really helpful to understand the market to go in a greenfield approach.
Well, certainly your focus on payers is very relevant for what you're doing at Health Language. And I want to ask you about what sort of impacts you've seen on payers during the pandemic. Of course, pandemics affected everybody, but what did the last 15 or 16 months or whatever it's been now look like for payers?
Yeah, I mean, it's been amazing, David, and crazy. I think in some respects, the tragedy of the pandemic and all the impacts to people's health and the economy, it has been a catalyst for change. I can talk a little bit about that, but examples like virtual health. We'll talk more about that in this discussion, but that really the necessity really is the mother of invention, and we showed that things change like that can be positive, and that some of the perceived barriers around it were overcome, and maybe we exaggerated. So some of the digital transformations have been accelerated. So we saw a catalyst on this, but on the other hand, we really saw sort of the some of the challenges of healthcare. We saw it amplified. We had a huge delay in care. So you have this large group of members and a typical payer who didn't seek care. I mean, ultimately payers got disconnected from members, where pre-COVID they were really putting a lot of attention into member engagement. It's important to them, but during COVID it got disconnected. And the old models where you just look at last year and then you project it forward. Last year, 2020, and the COVID, it was unlike anything else. So
it just went haywire, really.
Yeah, it just went haywire. And then you saw some of the things that we know around health equity problems just widen. You saw it, during the pandemic. You saw the need for behavioral health increase, where we knew that it drove and impacted health a lot. And we know loneliness, for example, impacted seniors. But when you saw some of these maybe these issues like behavioral health not totally being addressed properly, get amplified, especially with a segment like seniors, or social determinants of health is something that's been very big in terms of thinking about what drives health. And you saw those social factors amplify kind of the impact or inequity in certain people's care. So it, it highlighted this divide that we have and these problems sort of we have. So catalyst for change, but also, highlighted the problems. And, I think, people saw more clearly how we got to double down on our efforts.
So what would payers be expecting next? I mean, on the one hand, pandemic time was such a disconnect from what came before it. And then I guess there's a question of, well, now are we just going to have sort of a catch up on all the care that was missed? Are there things that are changed permanently? What's the impact of things like the disengagement, mental health issues, but also the digital transformation? I mean, what from a payer is their crystal ball any less cloudy than it was?
Yeah, I think when you look at the first, 6 months of this year, it's getting more clear. Payers in their crystal ball didn't know what to expect, and I think they obviously saw a peak in utilization this year in terms of people catching up. And I think early results of payers is that utilization's been very high, but it's what they expected.
Yeah.
I think what's unknown is what is the longer term effect of being disconnected from members and where care was ignored, what is a little bit longer term effects of that. And I think you see a lot of effort going in this year of reconnecting with members. We'll get into technology, but getting better data to understand the details of clinical health of members to better tailor kind of these programs. So there's a really reestablishment of going on this year, David, and trying to understand. And then, of course, there's a lot of consumers who are more comfortable doing wearables and being monitored. Virtual care is something kind of being demanded. I think 8 out of 10 who experienced virtual care in during the pandemic, according to Kaiser Health, were very satisfied with it. And it's multiplied, I think 10x on average in the last year. So we're not going to go back entirely at all, and I hope we don't go back entirely at all. Behavioral health, I don't think we'll go back entirely. I think the importance of it, even beyond the pandemic, and the linkages to health, I think payers are rethinking how to address that. And virtual care is part of that too. People have better access to mental health and behavioral health professionals through virtual care, and some are more comfortable that way, and some aren't. But those things are all improving health, and some of those I don't think will go back. I hope we don't go back.
Yeah, I think that payers, to some extent, were bought into digital health more than providers were beforehand. And then when the pandemic forced people's hands and they couldn't come into the provider offices, for sure, we found out that the patients like it, and providers seem to like it pretty well too. And I think the payers, need to figure out how to adjust their policies so it's maybe not totally wide open for use of telehealth, but it's to use the right intervention and the right type of visit at the right time. So I'll be interested to see how payers move forward with that.
Yes. And, really, I think this year is a lot about making things permanent and not bouncing back to status quo. And
right.
That'll be interesting to watch.
Well, let's talk about the role of technology for payers. And before looking ahead and see where they're going, I mean, what has the use of technology been like for payers in the past? And what are some of the lessons that have been learned in terms of key successes and failures along the way over the last, 5-10 years?
Yeah, I mean, there's been a lot. I think, payers, as you probably know, have been slow to progress and advance and innovate. And of course, payers have, created innovation arms and found new ways beyond kind of the four walls of operations to innovate. And so, I think in some of the failures has been the technology and collaboration between payers and providers. It's been slow. I mean, as value-based has accelerated, the innovation to connect in meaningful ways has come slow. Value-based has come slow, but certainly the technology to support it. And certainly I think payers, their access and knowledge of their members have been poor. And partly that's because they relied on kind of the data in their four walls, which is kind of claims data, and so there's been a failure to really understand clinically their members, and certainly value-based shifts some of that appropriately to providers, but I think even in value-based, providers expecting payers to share data with them, especially patient data that goes outside that provider's EMR, and using clinical data has been kind of a failure, and now you're seeing it accelerated to learn more about members and engaging differently and personalizing it and using it for analytics and improving overall outcomes.
Now, one of the things I know you do at Wolters Kluwer, and specifically in the health language business, is help apply some technologies now that some of the data become available to the payers that might be more useful. What are some of those technologies that you have in place or putting in place? How are those actually used by payers, and what kind of impact might they have?
Yeah, there's 3 or 4. One, I mentioned there's this shift of understanding member data better, and payers are getting more access to clinical data or medical charts. And one of our technology is natural language processing. We are getting a lot of traction in the payer market, where we take the unstructured data within a medical chart, which is significant amount of insight. We're turning that unstructured data into insights, and we're turning it into data that they can actually use to understand their members better. So that's getting a lot of traction around analytics or AI or member engagement, or just the member 360 view. That data is a gold mine, and payers are starting to see it.
You see,
so
it's certainly good
one.
that you had before just like the handwritten notes, and you couldn't do much with that. But now, as you say, an electronic medical record is electronic. A lot of it's not structured, so it's still the notes, and you need somebody or some kind of a technique to make sense of it. And NLP, would do that.
That's right. Yeah, I mean, I think coming out of meaningful use in the EHRs, it's a collection of a lot of data, but unfortunately, the real clinical rich data that is useful turns out, we estimate, and there's a lot of outside sources estimate 80% of the value or the insights around that patient or member is in the unstructured notes, in the doctor progress notes, and written by clinicians. And so if you can unlock that and turn that into insights that you can use in terms of these strategic imperatives, that's getting a lot of traction. And again, it's playing into the strategic imperative that payers have to learn, engage with their members, learn what their health is, and put programs around that to manage medical costs and certainly quality and ultimately the outcome.
Now, population health is something that's been talked about for a long time in different guises, and sometimes the meaning isn't completely clear. What does population health mean to payers these days? And what are their objectives, what they're trying to accomplish, and how do data and analytics tie into that?
Yeah, I mean, it's population health for payers. It is a buzzword, and it used to be called, some of these used to be called medical management. Some used to be called care management. A subset of it is like disease management. But what the goal is to understand the health of segments of the population and categorize them. So obviously, when you're looking at population health, one we always talk about is, diabetes with complications. So where you're putting them oftentimes around a disease group that have common interventions, common programs that work to keep them well, improve their outcomes. So it's identifying through clinical details categories of disease states for members, and then wrapping around actions that are delivered sort of at the right time for those that are impactful. Sometimes if you find those with conditions like some conditions are not as impactful, that there's nothing you can do to make them the outcome better, but in many cases you can. So it's wrapping programs. Disease management's a big one, but it's putting interventions, clinical interventions, sometimes by the provider, sometimes by payers or agents of payers, to wrap around and manage these diseases to improve their outcomes and just improve quality.
There's another technology that I saw on your site, and I don't understand it, and I'm hoping you can explain what it is, which they talk about code translation engines. What's that about?
Yeah, this is really interesting. I think if I could step back a little bit, and talk about kind of interoperability and quickly come back to code translations. There's been a lot of work, and there's been ONC and CMS mandates around improvement around the facilitating of data between payers and providers. And there's mandates that are eminent that really talk about the structure of the data. And so that's going to facilitate kind of a tsunami of data to payers. They're going to get access to more and more clinical and administrative data through these means, and so it'll be imperative that they, are very good at what we call semantic interoperability, which is getting a common meaning of the data. It's not just about structure, but it's a common meaning. What does all this data mean? And in healthcare, getting back to code translation, in healthcare, the meaning of data is done through standards, whether it's ICD-10, CPT, SNOMED. On lab, we have a standard called LOINC. There's RX norms. So codes are sort of the Rosetta Stone of creating a common meaning of data. So the step beyond the technical mandate is the ability to translate codes and make sure you normalize them and you have a common meaning. And if you're using them for pop health or member engagement or analytic purposes, you often need to translate one code, let's say ICD-10, to SNOMED or another. So translating these codes between standards to solve a problem in analytics is sort of the semantic interoperability or the hardwiring needed really to achieve these imperatives. And we specialize in standardized codes and in translating from one to the other. If labs come in, they're often missing kind of the code that describes the service. We call it LOINC. We use machine learning to kind of fill that in. So you've got this definitive code that describes the service or the procedure or the diagnosis in a standard way that creates meaning to the data, and therefore, you can then use it. It's sort of a requirement for analytics and, AI and all the things we've been talking about. And we call it the Rosetta Stone of healthcare data. You need it, and you need to have a common meaning, and we have that. I use the word Rosetta Stone because it's kind of a translation, but health data has all kinds of different languages through codes, and payers need to go back and forth between these languages to achieve certain applications, and that's what we do.
Great, makes good sense. Now, we've been talking about payers and providers, but of course, most of the big payers, I think actually all of them, have made some entree into the provider space. And then on the provider side, a lot of the big provider organizations own health plans. And so looking at that side of it, how did the plans that are owned by provider organizations differ from traditional payers, or is it in fact just the same thing?
Yeah, you see a growth of this, and you actually see different entities shifting risk to different types of entities. So you kind of have this risk shifting thing going on in the market. But, like 15 years ago, there were providers who created health plans, and a lot of them weren't successful. A lot of them were like UPMC. But more recently, I think, just like the advantages of value-based, where a payer and a provider play such vital roles, incentive and mission can align that then it generally turns out to be better outcomes for the patient. So provider groups or large health systems forming health plans, it creates really alignment on mission completely, and there's another level of cooperation that goes on back and forth between the entities, and some of them may be differences that you might see on separate entities go away. I a couple of years ago, David, that Blue Cross Blue Shield of North Carolina decided to form a Medicare Advantage plan and merge with Duke.
Right.
And so it became a new entity where Duke and Blue Cross North Carolina were kind of co-owners at the board level. And again, it was another way of creating alignment and cooperation beyond just a contract. And it seems to work so much better. So the health system forming a health plan just creates alignment across the board, and it certainly, you've seen a lot more successes recently when you've seen it, and like you said, like payers are buying primary care practices too, and they're extending it, so it's going both ways. But ultimately, is that really that integration where you have alignment of mission between those two entities, and that's where ultimately the goal is for the patient to have better outcomes. And so I see it as a positive.
I mean, of course, we were talking way back at the start of this podcast about Kaiser, so it's nothing new under the sun, I suppose, is the real takeaway.
Yeah, it's nothing new. I think Kaiser is just their DNA. They've always been that way.
Yeah.
And they're integrated through health. At least in California, they're integrated like all the way into the health system and ancillary services. And there's very, very different levels of sort of integration going on. And then, I see payers outsourcing risk to primary care practice groups, like CareMore. And so they're shifting some risk to entities to kind of, again, they're trying to gain alignment. Like, hey, if CareMore is at risk for taking care of patients, we have shared goals. We'll both share in the benefits, and ultimately the patient will survive. So you see a lot new models out there, but ultimately it's creating alignment between the stakeholders.
Good. Well, for the patient's best interest, I hope that they all figure out a good way to make it work. And it's good there's some good experimentation that's going on. Frank, I'm just going to turn to my last question, which is different from the others, and ask if you've had any chance over the last year or so to do any reading, and if there's any books or anything else that you would recommend for our listeners.
Yeah, we've had a lot of time to read, right, David?
Yeah.
And I think on the business side, I would really recommend a book called Scaling the Revenue Engine by Thomas Moore. Anybody who builds product, and especially in healthcare where you're trying to address a very dynamic market, it's a great book and gives some real insight in terms of how to think about commercializing and adding value. And so that's a good one. I also read, and I guess it's a movie now, so I always like to read books before I see the movie. But a book called Just Mercy is nonfiction. It's very moving, and it's a great book, and it's very thought provoking. So I'd certainly recommend Just Mercy.
Great. Those are good recommendations, and they're good because I'm sure they're good, but they're also good because they're not repeats of ones that I've already gotten from my interviewees.
Good.
So
Good.
This is terrific.
Good.
Well, great. Well, Frank Jackson from Wolters Kluwer Health Language, I want to say thank you very much for spending the time on the Health Biz podcast today to explain the payer perspective.
Thank you, David. It's been a joy. I really appreciate it.
You've been listening to the Health Biz Podcast with me, David Williams, President of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.